Greetings. It's a great pleasure to be part of this International Union of Phlebology to exchange ideas with physicians from around the world. Here are my disclosures. As you know, COVID-19 is a virus-induced inflammation that's it triggers a cytokine storm causing tissue factor release, thrombin generation, fibrin formation to coat the virus and prevent spread. Gee, that's terrific. It would coat the virus. That's not exactly what happens. The unfortunate side effect is thrombosis and activation of thrombosis, and arterial or venous clots can occur anywhere in the body where there's a blood vessel. But of all of those places, a particular place is the alveolar endothelial interface where it attacks, and the virus is like spears piercing the endothelial interface, facilitated by ACE2 receptors producing all of these reactions. And I'd like to talk about these reactions from the standpoint of the eyes of a famous hematologist, Oscar Ratnoff, who discovered a deficiency of factor 12 in John Hageman, named it Hageman factor, and showed with experiments done before the turn of the 20th century how Hageman factor could by itself activate platelets, coagulation, fibrinolysis, complement, and kallikrein, leading to thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypertension. Wow. That's COVID, folks. And furthermore, he went on to say, and I'm going to read this, the thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The processes through which it defends itself are interlocked like pieces of a puzzle, jigsaw puzzle. We may be intrigued by the intricate pieces of the puzzle, but the picture emerges only when they are put together. And we have learned since, of course, that anticoagulation alone is not the answer, but we've learned some other interesting things about anticoagulation, and we'll get back to the tangled web. One study that really shocked us was this study, which was a big international study showing that in moderately ill COVID patients, full anticoagulation cut down on the need for organ support and mortality. But it did nothing in severely ill patients in ICU. All it did was increase their bleeding. And this was a surprise to a lot of us. And on the heels of that comes the ACTION trial, which did a similar type of evaluation using a rivaroxaban, and that didn't pan out. And it's clear that rivaroxaban or the DOACs are not really suitable for this phase of the disease. The Hep COVID trial came out, and this was a very interesting trial, again, comparing patients to the non-ICU and ICU stratum. And in the non-ICU stratum, the incidence of the primary endpoint was halved in patients on therapeutic anticoagulation compared to prophylactic anticoagulation, with no real increase in bleeding. And overall VTE events and death were improved. And if you take a look at the ICU stratum, on the other hand, the opposite occurs. You don't see, first of all, in the ICU stratum, there's no real difference in the incidence of thrombosis. And the bleeding rate is higher, 4.7% compared to 1.6%. Recently, a randomized prospective analysis, doing a meta-analysis of the 4 randomized trials appeared, and they again concluded that therapeutic dose heparin was associated with the lower rates of major thrombotic events without differences in bleeding risk and mortality in hospitalized non-critically ill patients. Now let's go back to the tangled web. Some of us feel that perhaps one of the reasons for the early and great success of full-dose anticoagulation in this disease is related to blocking or blunting Hageman factor, which helps to slow down a little bit this massive chain reaction that occurs with the disease. Now, we all know about individual risk assessments, but that's been hard to do in COVID, but we're getting there. The one small study that we did compared the improved score and the Caprini score for VTE and mortality in COVID-19 patients. Here's the Caprini score, and here's the improved score. The improved score, if the score was moderate or high, the incidence of mortality jumped from 15 to 68%. So it really worked to identify mortality. Caprini risk score is broken down a little differently, as you know, and there's a difference between the low risk and the highest risk of DVT incidence from 0 to 30% and mortality from 0 to 80%. Most of these patients, by the way, were unvaccinated. Since that time, the Michelle trial has appeared, and the Michelle trial has used the improved score with D-dimer to identify a group of people that might benefit from 35 days of rivaroxaban post-hospital discharge. And we can see here the results clearly statistically significant. This is a small study, but it certainly is a game changer. And we're again reminded about the importance of history because they did the same thing with rivaroxaban before COVID. And I'd like to finally focus on this slide, which is a beautiful schema taken from a very, very well done paper by the International Society of Hemostasis and Thrombosis, showing the state of the art right now as far as the trials are concerned. And you will notice that prophylactic dose is preferred over nothing in COVID-19 in hospitalized non-critically ill patients, and therapeutic dose in individuals, selected individuals. The discharge, post-discharge, it was a small trial with Michelle, so that has been considered, but we need more data. And finally, in summary, never kill a friend, never treat a stranger. When you meet a person, you've got to interview them and interrogate them so that you know all of their risk factors, especially if they're a COVID patient. And then, of course, you would never, ever kill a friend because you would know their risk and you would protect them, and you'd never treat a stranger. So I'd like you to view my website and my social media platforms, and I thank you very much for this. And I thank the organizers of this conference for the privilege of presenting, and I look forward to hearing a lot and learning a lot from the other participants. Thank you very much, and I hope you have a great meeting.